Welcome back. I'm an emergency doctor actively working at the emergency department of my hospital. In this Doctor's Corner series, we'll dive into lesser-known approaches and hidden strategies to help the people with critical illnesses. You can subscribe if you want to learn the latest news and healthy solutions about your health. Let's begin with one command. Do not think of depression as only a sadness problem. Think of it as a whole-body signal showing up through mood, sleep, appetite, energy, inflammation, stress hormones, brain, plasticity, and sometimes even mineral balance. Now ask the first important question. Why would a simple mineral like zinc matter in something as complex as depression? How could something found in oysters, beef, pumpkin seeds, beans, nuts, dairy, and fortified foods have any relationship with motivation, emotional resilience, or mental heaviness? Here is the key. Zinc is not just a nutrition detail, it is a signaling mineral. It helps regulate neurotransmission, immune activity, oxidative stress, brain-derived neurotrophic factor, often called BDNF, and the stress response system known as the hypothalamic pituitary adrenal axis. A recent review of zinc homeostasis in major depressive disorder describes zinc as being involved across neurotransmitter regulation, BDNF signaling, inflammation, oxidative stress, and HPA axis activity, which means zinc sits at several crossroads where depression biology often becomes disturbed. So, listen carefully. Do not use zinc as a magic word. Use it as a biological clue. Depression may require psychotherapy, medication, sleep repair, trauma-informed care, exercise, social reconnection, treatment of medical illness, and crisis support when needed. But when zinc is low, poorly absorbed, or biologically mismanaged, the brain may be trying to run an electrical system with missing circuitry. How do we respond to that? We restore the missing piece thoughtfully, safely, and with medical awareness. First, understand the evidence. In depressed patients, lower serum zinc has been observed repeatedly. In one placebo-controlled double-blind study involving patients with major depression treated with imipramine, depressed participants had serum zinc levels about 22% lower than healthy volunteers. Treatment-resistant patients had still lower zinc levels than treatment-responsive patients. The study also found that, after 12 weeks, higher serum zinc was negatively correlated with depression severity, meaning that as zinc status improved, symptom burden tended to be lower. Now ask, why does that matter clinically? Because it suggests zinc may not be only a dietary number. It may behave like a state marker in some patients, something that shifts with the illness and the response to treatment. Do not overstate this. A blood zinc test is not a standalone diagnostic test for depression, but do not ignore it either. If someone has low appetite, chronic stress, gastrointestinal disease, heavy alcohol use, restrictive dieting, high phytate intake from poorly prepared grains and legumes, pregnancy, older age, or long-term inadequate protein intake, zinc status deserves attention. Second, look at intervention evidence. In a double-blind randomized clinical trial, 44 patients with major depression received either 25 milligrams of zinc daily as an adjunct to SSRI antidepressant therapy or placebo for 12 weeks. Depression severity was tracked using the Beck Depression Inventory, and the zinc group showed significant reductions from baseline at weeks 6 and 12. Pause and ask, how can a 25 milligrams mineral dose influence mood symptoms? The answer is not one pathway, it is a network. Start with glutamate. Glutamate is the brain's major excitatory neurotransmitter. Too little signaling is a problem, but too much uncontrolled excitation can become damaging, agitating, and metabolically expensive. Zinc interacts with the glutamatergic system, including NMDA receptor activity, and reviews of the glutamatergic theory of depression describe zinc as a modulator of this system. So give the brain this instruction: calm the noise before demanding motivation. In depression, people often blame themselves for low energy or slow thinking. But what if part of the problem is not weakness, but dysregulated signaling? Zinc may help stabilize the balance between excitatory and inhibitory tone. That does not mean zinc sedates the brain. It means zinc may help the brain signal with better control. Next, consider BDNF. Ask, how does the depressed brain recover? It does not simply think positive. It remodels. It needs neuroplasticity, the ability to adapt, form new connections, and strengthen circuits involved in learning, emotional regulation, and resilience. Zinc has been linked with BDNF-related pathways, including signaling through the zinc-sensing receptor GPR39 and downstream CREB-BDNF activity. Tell the audience directly, do not separate mood from brain repair. If depression has narrowed someone's world, reduced pleasure, and made ordinary tasks feel impossible, then recovery must include rebuilding capacity. Zinc may support that rebuilding environment, especially when deficiency or marginal status is present. Now move to inflammation. Ask, why do many depressed people feel physically sick, heavy, achy, inflamed, or exhausted? Because depression can overlap with immune activation and oxidative stress. Zinc participates in immune regulation and antioxidant defense. The NIH Office of Dietary Supplements describes zinc as essential for many physiological processes, including immune function and cellular metabolism. Psychiatric reviews connect zinc imbalance with inflammatory and oxidative pathways relevant to depression. Give this command. When depression looks like fatigue plus body heaviness, investigate the body, not only the mood. Check diet quality. Check sleep. Check thyroid, anemia, B12, vitamin D, inflammatory disease, substance use, medications, and zinc status when clinically appropriate. How many people are told it is all in your head when the head is connected to the gut, immune system, liver, endocrine system, and diet? Do not make that mistake. Now look at stronger pooled evidence. A comparative dose-response meta-analysis of observational studies and randomized controlled trials reported that zinc supplementation significantly lowered depressive symptom scores in depressed patients, with a weighted mean difference of about 4.15 points. It also found that the highest zinc intake category was associated with a 28% lower risk of depression in cohort studies. The authors still emphasized the need for further trials, especially to clarify when zinc works best as monotherapy versus as an adjunct. This is where we must be clinically mature. Do not say, zinc cures depression. Say, zinc may help a biologically selected subgroup, and the signal is strong enough to respect. That sentence is more useful. Why? Because depression is heterogeneous. One person's depression may be driven by trauma and insomnia. Another person's depression may be driven by bipolar disorder. Another may have inflammation, poor diet, low zinc, low iron, hypothyroidism, alcohol use, chronic pain, or medication effects. How should we respond? Stratify, personalize, measure when needed, treat the whole person. Now make it practical. First, start with food. Do not run immediately to high-dose supplements. Build a zinc pattern. Oysters are extremely zinc-rich. Beef, crab, lobster, poultry, dairy, pumpkin seeds, cashews, chickpeas, beans, whole grains, and fortified cereals also contribute. But ask, how absorbable is the zinc? Animal sources tend to be easier to absorb. Plant sources can be valuable, but phytates in grains and legumes can reduce zinc absorption. So use soaking, sprouting, fermenting, and balanced meal design when plant foods are the main source. Second, check the dose if supplementing. The label usually lists elemental zinc, and that is the number that matters. Many clinical studies used about 25 milligrams per day. A cautious adult approach is often in the range of 15 to 25 milligrams elemental zinc daily for a limited trial, especially when intake is low or lab status suggests deficiency. But do not exceed the adult tolerable upper intake level of 40 milligrams per day unless a clinician is supervising. The NIH notes that excessive zinc can cause nausea, dizziness, headaches, gastric distress, vomiting, appetite loss, and, when used too much or too long, copper deficiency, immune changes, and lower HDL cholesterol. Third, protect copper. Why? Because zinc and copper compete. Too much zinc for too long can quietly push copper down, and low copper can cause anemia-like symptoms, neurological problems, fatigue, and worsening weakness. If someone is using zinc beyond a short period, tell them, do not improvise. Monitor, balance, and involve a clinician. This is especially important for people already taking multiple supplements. Fourth, separate zinc from certain medications and minerals. Zinc can interfere with absorption of some antibiotics, and large iron doses taken at the same time can reduce zinc absorption. The NIH notes that supplements containing 25 milligrams or more of iron can reduce zinc absorption when taken together, and zinc products may need timing separation from certain medicines. Fifth, watch the timeline. Do not expect a mood transformation in 2 days. In studies, changes were often assessed over 6 to 12 weeks. Ask, how will you know whether it is helping? Track sleep, appetite, morning energy, irritability, rumination, motivation, social withdrawal, and a validated mood scale if possible. Do not trust memory alone. Depression distorts memory. Write it down. Sixth, know when zinc is not enough. If a person has suicidal thoughts, psychosis, mania, severe inability to eat or drink, severe functional collapse, or danger to self or others, move immediately to urgent professional care. NMH emphasizes that depression treatment may involve therapy, medication, or other medical interventions, and that life-threatening situations require emergency help. In the United States, 988 is available for suicidal or emotional crisis support. Now ask the deepest question. Why does zinc feel so conceptually powerful in depression? Because it changes the conversation. It moves us away from blaming the person and toward understanding the system. It says, perhaps your brain is not broken. Perhaps it is under-supported. Perhaps your mood is not a moral failure. Perhaps it is a signal. Perhaps recovery requires both meaning and minerals, both therapy and physiology, both connection and cellular repair. But keep the balance. Do not worship the supplement. Respect the biology. Zinc can be beneficial when there is deficiency, marginal intake, inflammatory burden, or a pattern that fits. Zinc can be ineffective when the depression has other dominant drivers. Zinc can be harmful when overused. The art is not taking more. The art is taking the right amount for the right person, for the right reason, with the right monitoring. So, here is the final message. Treat zinc as a high-value clinical clue in depression, not as a shortcut. Ask why the brain is inflamed, exhausted, overstimulated, or unable to rebuild. Ask how nutrition, stress hormones, glutamate balance, immune signaling, BDNF, and mineral status are interacting. Then act carefully. Improve zinc-rich foods, assess risk factors, consider testing when appropriate, use modest supplemental doses if justified, protect copper, avoid long-term excess, and coordinate with mental health care. Depression is not simple, and that is exactly why zinc deserves attention. It touches several systems at once: neurotransmission, plasticity, immunity, oxidative defense, and stress regulation. When used wisely, it may help turn the body from a state of depletion toward a state where recovery has more biological support. Take care of your mind, take care of your body, and take care of one another. We are learning this together, like a family committed to getting healthier with each conversation. See you in the next topic.